Welcome to the First Principles of Medicine podcast. In this series, we will be breaking down complex medical topics into their first principles. When the stress is on and you've just been asked a tough question that you don't know the answer to, we feel you'll be able to fall back on these principles to formulate a decent answer and perhaps reason your way out of trouble. Before we get started on our first episode, let me introduce the team. My name's Adian, and I'm joined by Jason, Dan, and JT, who will be leading the discussion on our first topic, which is stroke. Take it away, JT.
Yep. Okay. This is a condition that I think is the third largest killer in the world. Making that stat up, maybe.
Are you making that up or not?
I think I'm making that up.
Why are you telling us that?
Because I don't have the stat.
Literally 1 minute and you're lying. Already.
Maybe it's the top five. One of the top 5 conditions in the world.
Oh, I forgot to ask him whether he watched the Super Bowl.
I was watching it while I was taking a history.
Oh.
Because it was playing on the TV. So
how good was your history?
I don't know.
3-hour history. Brought his own chair in.
Yeah.
Anyhow, so we're talking about stroke today. So to start off, I have trivia to ask about stroke. Let's start off. What's the mnemonic for stroke? When you recognize stroke, what should you think of? It's a 4-letter word. Let's play a bit of Wordle here.
Face. Is it?
Face
Fast.
is not the one.
Fast.
Is it fast or face?
I don't know. Which one? Are we going to choose
No, but
one?
fast, and what does the F stand for?
Face.
Face.
Or face.
I think it's fast.
Symmetry.
It's fast.
Okay, so the word,
Let's fill this in. Yeah. Okay. All right.
mnemonic is fast.
F is face. Good. The next word in fast is letter is
A.
A stands for
Arm. Is it arm?
Arm symmetry?
Arm drooping?
keep going.
Arm drop.
And then S.
Is it arm?
I'll go up.
Okay. Yes.
S is speech.
S is
Slurred
speech. No Googling.
No, I haven't yet.
Don't.
Jeez, Dan, you're not perfect, man.
And then
T timing.
T is time. Nice, good. So in one survey, 93% of the people was able to recognize one of these symptoms, and only 38% were able to be aware of all these 4 symptoms and knew to call 911 when someone was having a stroke.
911, the American...
Oh, it is 911. I don't know.
I think if you dial 911 in Australia...
Doesn't it work anywhere?
Yeah, it works anyway.
They just rewrite it to 000.
Yeah, because of all the movies.
Yeah, it makes sense.
Is it 000?
Yeah,
Is it
actually.
000?
I think it's
000.
Yeah.
Because people like JT just freaking...
Well, you watch movies, you think,
Yeah.
oh, 911.
Is there 110? Is that a number?
Probably different countries have different ones.
No idea.
Okay, whatever. All right. The last letter there was T, right? So what
Yes.
does T stand for?
Time.
Time. So the common adage is time is brain, correct?
Sure.
So you've got to, if someone has a stroke, depending on which stroke, and we'll get into which stroke later, you lose a lot of neurons per minute.
Right.
Yeah, and usually it's not by the minute, it's probably by the hour, right?
Sure.
We know that golden hour thing. It depends on the country as well. Do you know that golden hour in which you should use this medication? Have you heard of that? There's a golden hour. No?
No.
You should give someone this medication if they have a ischemic stroke.
Streptokinase or something.
Yeah. It's
Alteplase.
TPA.
Yeah.
Do you know that time frame in which usually you have to give this medication?
12 hours.
Is it within 4 hours?
I thought it
4
was
hours.
dependent on whether you're near a tertiary centre, which can do thrombolytics. So.
I've heard 3 hours, 4.5 hours, and then I think somehow 12 hours is it's went a bit lenient about that.
Okay. 4 hours probably good.
But sooner is better, right?
Yeah.
Yes, but usually you don't see when the patient first has a stroke.
Yeah.
Usually they're maybe asleep, and then you only find out they have a stroke when they wake up.
Yeah.
Or you find them on the ground.
How do you determine time in that instance?
Time in that instance is based on when the person was last seen to be healthy or normal.
You can't predict it by via radiographs and things like that? As in
Not
changes
sure.
on the CT or something?
I'm not sure. We'll talk about the management. Yeah, but I know 4.5 or 4 hours is the time frame.
I don't think that brain thing is worth that much. Is it that important?
I mean, clearly you don't use that much.
Not yet. You haven't hit 25 yet, right? So
Yes.
you're still increasing
young
your amount
man.
of neurons. Okay, now we're gonna get into some first principles before we go into stroke.
Sure.
Right. 2 first principles. The first will be Virchow's Triad, right? And the second part is the regions of the brain, and I'll give you a bit of, a bit more clues into that, and then that will help us understand the different categories of stroke and then the different clinical features of stroke. So, we have 3 parts of Virchow's Triad. Can we name one each? Do you remember all this first principles?
Turbulent blood flow.
Good, yeah, that's it. I think that leads to stasis in different areas of the vessel, right? Can you think of some things which could lead to turbulent blood flow, for
like
example?
things like plaque. If you've got hypertension, it's
Yep.
turbulent.
Yep.
Bifurcation, like with arteries.
Yeah.
That's why you get a lot of plaques in the carotid where it
Oh, where it
bifurcates into
bifurcates, yeah.
into an
Structural
extremity.
abnormality, just like
Good. Any activities that we usually ask for when, for example, someone has a DVT? What have you recently
So
done?
turbulent, yeah. So stasis probably is stasis included in turbulent.
Yes,
blood flow?
stasis. Yeah. So what kind of activities leads to?
So being immobile.
Yeah. Okay.
sedentary.
On a plane.
On a plane, usually that's what we ask for.
Surgery.
Surgery,
lying in
yeah.
bed.
Yeah.
Good. Any questions there? Or you've been driving
Are
for
we
a
are
long
we
time?
sure are we sure turbulent blood flow comes under the banner of vascular stasis? It doesn't
I
cause
think-
endothelial dysfunction. Sorry.
All right, so you have
That's
the
it.
second one. All right, let's move on. So endothelial, I think they're all related, right?
Because the turbulent blood flow, like it means that you don't have the blood cells in the middle; they're flowing around and hitting the sides of the artery and potentially damaging.
I
it a
was
little bit.
thinking of like laminar blood flow is when there's no stasis, right? Laminar is the normal one.
Well, yeah,
right?
laminar
and
is
then
normal
turbulent
blood
is, I guess, because
Friction on the walls.
and then there'll be
because if
an area of
you have
stasis.
turbulent blood flow, it's parts of the blood flow which are static. It's not all flowing at the same time, right?
like your appendage in the
Yeah.
left
Because
atrium.
imagine there's obstruction, there's areas where there's fast
Yeah,
blood
and-
flow, and then there's areas where there's the blood
Slow.
flow is really slow. It's like tucked in.
Like a backlog.
All right, we went to the second one. So Dan, what did you say earlier? The second.
endothelial dysfunction.
Yeah, good. All right. So what kind of things can
Smoking, uncontrolled diabetes,
Yep.
hyperglycemia,
medical conditions?
medical
Yep.
conditions, hypertension, so high blood pressure, toxins, hyperlipidemia.
Good.
Okay, so it's just anything which damages.
I'm just as a brainstorm, really, just to get everyone refreshed back.
No,
to
just
the
running with.
points.
So when you say endothelial dysfunction, essentially anything which damages the vessel wall.
Yeah,
Okay.
yeah. So
There's
going
a lot
back
of
to our
things.
glomerular thing, could have been something like that too. Vasculitis, I guess.
Yeah.
And then the last one,
Hypercoagulability.
nice. And going back to one of the exam questions, what's one of the things that could lead to hypercoagulability?
I got this, guys. I got this.
I actually got two.
I've had to do this so much in the stroke ward that essentially, come on,
What is
bring
it?
it up.
Factor 5 Leiden?
Yes.
Factor 5 Leiden is one of those.
Is Factor 5 Leiden, is that a deficiency? As in, or you have too much of it? I can't remember.
Isn't it
Deficiency.
I don't
it's
know.
a deficiency? Is it the deficiency
In Factor 5?
Factor 5.
or is it like protein C and protein S?
That's a separate one.
That's a separate one. Okay,
Yeah.
so yeah, factor 5 Leiden deficiency and factor 5.
Yeah.
I
Yep.
remember I wrote 3 great answers,
What was your third one?
which got me
No marks.
2 out of 3. I wrote protein C
How do you know you got 2 out of
deficiency,
3?
protein S deficiency, and protein K deficiency.
How do you know you got 2 out of 3?
No,
Vitamin
I assume
K.
I did,
Okay,
so-
sure.
No. What I
Is
was
there
going to
protein?
lead on, the
Oh.
protein K doesn't exist. I was like, I totally forgot factor 5 line.
It's all right.
And I was
It's all
like, protein C, protein S.
Yeah.
I was going to chuck in a protein A. I didn't even know what that was. But you
Sure,
know
protein-
what?
protein
I
J.
got 2 out of 3.
J for Jason.
And one thing that we look for in a particular demographic, they usually take
sickle
this.
cell anemia.
Yeah, good. Yep, that's one thing. That's in,
Also, I'm not- yeah.
I'm talking about the opposite of male.
Oh, being a woman.
What could lead them to have more
Estrogen.
estrogen if they take the pill or if they have recently been
Pregnant.
And
pregnant? Yeah,
another thing,
yeah, good.
which I learnt about in this PE lecture we watched, was that active cancers increase your risk of things
Yeah.
like DVT. So I think it increases your hypercoagulability.
Makes you
Yeah.
hypercoagulable.
Okay,
Gotcha.
so that was just a quick recap on why blood clots form. That's Virchow's triad, and eventually a clot goes up to the brain, causes a stroke. We'll come back to that later. The second part, important thing about the stroke, and a lot of the clinical features are dependent on where the stroke attacks the brain.
Yep.
Okay, so a quick recap on the 4 regions of the brain.
I'm gonna
If we
tap
can
out
get
here.
that. What's the one right? You can do this one. What's the one right in front of us? As part of the word, I've already given it to you.
Like frontal cortex.
Lobe, the frontal lobe.
Frontal
So
lobe,
there's
yeah.
4 lobes. Okay, the frontal lobe, right? What is that responsible for usually?
Thinking.
Executive thinking.
Yeah, executive function. Yeah, good. Executive function. Yeah.
Yeah.
Yeah, good.
When you say executive function, what do you actually mean? Like making decisions, like
Those higher level.
High level.
You're trying to put things together.
like algebra? Like,
Yeah.
Sure. Yeah.
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 that's what-
Planning
It's like-
tasks.
So what does an executive at a company do? Make decisions.
Decide what to eat.
Exactly.
Yeah.
Brain decides what to eat, doesn't it? That's
Okay.
the part of your brain.
The other clue here. Imagine the brain. So you've got the left and right,
Big
and then
hands.
we cut it in the middle. let's say there's a anterior portion and a posterior portion that we use to describe. The anterior portion is used for like doing things. What is that? It's also known as the blank cortex, and then the back part is for feeling things. Is also known as the blank cortex.
Like the motor cortex.
Is the front part is the anterior, and then the back part is the
somatosensory.
Yeah, good. Motor and sensory cortex. Okay, and then to describe the brain homunculus, because it'll be important in describing our clinical features. So whatever I mentioned here will be helpful for later. The front, I don't even know how to describe this. I'm going to show it to you, Jason, and I guess everyone can see this homunculus.
Isn't there like a little figurine thing you can
There is that figurine thing that I have over here. So I'm going to try the front part, the anterior side of this homunculus relates to the lower parts of the body. So our toes, our knees, trunk, and then it goes on up. Close to the medial side, you have your shoulder, your arm, elbow, wrist, fingers, and thumb. And these have, if you think about the sensations that you feel normally, your fingers have a lot of
sensation.
You can feel
specific sensation. Whereas if I point to you on your back, you won't know exactly where on your back, but it's a wide area, right? So it's less sensitive.
Sure.
And then the largest parts would be up. If you go more posterior, it goes up to your face, your eyes, your lips, your jaw.
Right.
Okay?
Yep.
So the anterior is lower part of the body.
Yep.
The medial is the upper part of your body.
Yep.
And then the posterior is your vision, your face
Yep.
areas, rough areas, okay?
Yeah. I'm just picturing a human body lying on the brain, and then it's like distributed.
Yeah.
From like the medial, the middle part laterally.
Yeah.
I think of it like, I read it in this like Neuroanatomy for Dummies book. It was like upside down guy named HAL. So you've got HAL, head, arms, legs, and he's upside down. So the lateral part is the head, and that's laterally.
And then
arms,
and then
legs on the medial part.
That's good.
Wait, do that again? Wait.
And upside down.
So laterally is what?
Laterally, you've got your arms, your head.
Yeah.
Well, sorry, head, arms,
Legs.
then legs.
So legs is medial.
Yeah.
Arms is the middle, and then laterally is
head.
Yeah.
And then you've got bigger parts towards, like you were saying, the hands and the face, because you've got so many more neurons, because you've got more fine motor control, more fine sensation, better discriminative touch and things like that.
All right. So now we're going to a bit of definitions of strokes. So firstly, and this is a common misunderstanding, what is the difference between a TIA and a stroke?
So I believe
Brainstorm.
Yep,
Adian.
the difference between a TIA and a stroke is when you see evidence of it on MRI, classify as a stroke. If you haven't seen evidence of it, it's classified as a TIA.
Good.
That's correct.
Yeah.
That's the newest criteria, apparently.
Or if this, sorry.
So it's just whether you can see it on a.
If you see evidence of pathological damage, you retrospectively can call it a stroke. I think.
Okay.
Are you saying that?
And then I think it's or if the symptoms last longer than 24 hours still.
So I think they've changed that to needing radiological confirmation to distinguish. Is that right, Jacob?
Yeah, that's correct.
Okay, I thought they just added it on. Okay.
No, so they used to use 24 hours, and now they've not used that definition anymore, and it has to be backed up by radiological findings.
Cool.
And so that's actually one of the first few things that you do as part of management of stroke workup. You need to get a...
Is it MRI or CT?
You'll have to get a CT. We'll have to get a CT.
CT first.
Because usually it's much faster than
Yes,
MRI.
definitely, yeah.
But MRI can also be used, but usually you don't have that liberty of time. Yeah, that's correct. And we're talking about neurological symptoms, right? So it has to be a neurological injury. And if we go to the two big categories of stroke, the definition of a stroke is an acute neurologic injury caused by either A or B. What are these two things? These mechanisms that I'm talking about. These are two big categories of stroke.
So ischemic?
Ischemic is the biggest category of stroke, yep.
So by ischemic you mean just lack of blood flow to the area?
To that neuron, to that brain cell, yep. And that makes up 85% of all the strokes. But what is the other mechanism that is?
Hemorrhagic stroke.
Hemorrhagic stroke, good, yep, nice. So that's 15%.
So that's when blood vessel goes boom and explodes.
Yeah, good.
It's blood going everywhere in the brain.
So I guess a way to think of this is a blood clot going to be more likely to cause ischemic stroke, or is it due to a bursting of a vessel?
I think the ischemic one's more common
Yeah.
by virtue of more strokes being attributed to an ischemic event. Blockage event.
Yeah, that's what I like to think about. Yeah. Within hemorrhagic stroke, so we're trying to break it down even more. So we have A and B, right?
Yeah.
So breaking hemorrhagic, you can bleed within the brain, or you can bleed around the brain. And so that's different names. Would you know those names? Within the brain?
Subdural hemorrhage? No. Intracerebral.
Intracerebral. Intracerebral. Yep. And then the other one around the brain is subarachnoid hemorrhage.
Right. Okay. Yeah. So between the arachnoid matter and the brain.
Yeah.
Okay.
Yeah. So roughly speaking, these are three of the biggest categories that we can talk about. Interesting aside, I guess, because I'm on neuro. Do you know that this is a neurological finding? It's called subacute cerebellar degeneration. Have you heard of this?
I've heard it.
You've heard of it?
2 seconds ago, yeah.
Oh, okay, all right. And one of the things that leads to this cerebellar degeneration, it's subacute, is a B12 deficiency. And what's one of the most commonly known causes of B12 deficiency? Alcohol, yeah. Actually, that's one. But this patient that came in was 21.
Yeah. Vegan.
Not vegan. Not vegan.
Celiac.
Recreational drugs. What kind of recreational drugs?
Oh, Nangs.
Yes.
Yeah.
That was ridiculous.
Yeah.
And in his medical...
What is actually in the Nang? I always get mixed up with.
N2O, nitrous oxide. And somehow that then affects the pathway in which B12 is metabolized into its active form. And if you take a history from this guy, did he do 10 Nangs a night for 30 days? 100 Nangs a night?
No.
1,000 Nangs a night for 30 days straight?
You can't do 100 Nangs in
My boy did 1,000
No,
Nangs.
you can't. Seriously, 1,000. Are you just breathing?
Nangs like this.
I'm telling you, this is an actual person.
I'm breathing nitrous oxide. That's like
It's not that big. If
It's
you
like this big.
1,000.
Hey, I didn't say the answer. I said 10, 100, 1,000.
That is
100.
I'm going 1,000.
No, I'll be 100.
It was 100. Yeah, 100 a night over 30 days, which is
3,000.
3,000 Nangs. How ridiculous is that? We initially were considering between two possibilities, and then when his history was like Nangs, everyone was just like, "Oh, it can't be the other one. It has to be subacute."
3,000 Nangs.
How do you how do you report that like 300 canister years? Like what's his canister years? 100 canister years.
And so the patient education management of that was like, can you tell your friends not to do Nangs as much anymore because you could end up like this?
Yeah. Patient education is very important.
So yes, Nangs, N2O can lead to neurotoxic damage.
You should say that about everything.
Yeah. Okay, going back to ischemic and hemorrhagic strokes, right? So let's talk about the risk factors.
Nangs.
Nangs is better. Nangs?
For stroke, I'm actually not sure.
It's like, wait, okay. No, it probably is. I know.
But going to the first principles.
Anything which causes cardiovascular disease, primarily atherosclerosis, kind of.
Good, and that links to Virchow's triad, right?
Yes.
And then leads to stasis of blood flow and, yep.
So atherosclerosis has got a ton of things. You've got,
name them. Let's.
Oh my God, there's always
name 5.
The non-modifiable.
Name 5.
Age.
Actually, yep, that is actually the highest non-modifiable for stroke is age.
And it's also a risk factor for pretty much everything.
Yep. The highest modifiable risk factor for stroke is something we're talking about relating
Smoking. Really? Smoke, surely.
Diabetes?
Nope.
Hypertension?
Hypertension, yeah. That's the largest modifiable one.
Yeah, true.
And that applies for both ischemic and hemorrhagic. And I guess hemorrhagic is, why would it be for hemorrhagic?
Increased pressure.
And then might burst, right?
Yes.
Can lead to the microaneurysms. And then also a burst of a baryaneurysm is a classic of a thunderclap headache, which is also typical of a, what kind of stroke?
Hemorrhagic stroke.
Specifically?
It's a
subarachnoid hemorrhage. Yep, good. So you're talking about earlier diabetes.
Diabetes.
Good.
The babies?
Diabetes, yes.
Diabetes. Yep, okay.
Oh, is it mellitus or insipidus?
Any questions?
Sorry.
No, that's pretty straightforward.
Moving forward?
Yep.
Okay.
Probably should mention AF.
AF, yes. Actual conditions.
Because
important
just
one.
AF causes turbulent blood flow because the heart is not synchronous.
Yeah, good. And do you know where commonly the clots form within the heart due to AF?
The left atrium.
Specifically, there's an area, appendage.
Yeah.
The left atrial appendage. I don't know what that word means, but I think it's like this area, I guess.
It's like this little, you can actually see it on a chest x-ray. I was going over
can
it
you?
the other day.
It's
It's
a
like this
little
little
bit.
darkness, anyway.
This little...
Yeah. pouch.
Yeah.
Yeah, good.
Yeah, nice.
Another one that patients usually present with up at the neck, they'll be like, oh, I have really terrible neck pain. Not headache, but neck pain. What artery runs along your neck?
Carotid.
Yeah, and so you can usually hear it in dynamic maneuver when you lean forward in expiration.
Carotid bruise, right?
Yeah, and that's the condition is carotid artery stenosis. Yeah, so that's another actual condition that can lead to ischemic or hemorrhagic stroke.
Probably both.
Ischemic.
More so ischemic. Right. And atrial fibrillation, ischemic or hemorrhagic? Ischemic, because these are all little clots forming within the vessels that eventually end up into the brain.
Shoot up into the brain,
Yeah, good. So let's go back to the anatomy of this thing.
Sure.
So you're holding up your neck, and say you have the carotid artery, say you have atherosclerosis there, and there's a blood clot that goes up.
Yeah.
Do you know where the internal carotid goes up to? So it goes up to your brain through the whatever arteries. Do you know, there's a circle up there. Do you know what that circle's called?
Bruce Willis.
Bruce Willis is circle, yeah. Die Hard.
Sorry.
Yeah, good. So the Bruce Willis circle.
Imagine if someone actually
No.
Circle of Willis.
Circle of Willis for our...
Wait, it's called because of Bruce Willis, right?
They just love Die
He's
Hard
actually a
that
neurologist
much.
on the side.
So the internal carotid will connect to what cerebral artery? So there's 3 cerebral arteries here. The anterior, the middle, and then what's the opposite of
Posterior.
anterior? Yeah. So where would the...
I assume it's the middle, just because it's the middle of the circle.
Yeah. I think I don't know how else to derive that, but that seems right to me. And so typically in the stroke, where, according to the information I've just given you, which artery territory is the most commonly affected territory in a cerebral infarction?
I thought it was a middle cerebral artery.
Yeah,
stroke.
can you see why now, or?
I can, but
Yeah.
I don't know if my logic is
Let's try to
correct.
My logic's probably the same as yours, based on the information I just told you. So
So the middle cerebral artery is affected
yeah, why is that the most common?
because it's where the internal carotids meet.
Yeah, it keeps going up, and then it goes to the MCA territory.
Yeah.
Yeah, good. That's it. So the MCA and the ICA are the 2 most
Okay,
common.
so just let me. So it goes internal carotids, and then it goes to the middle cerebral artery,
Yeah.
and then the middle cerebral artery is where most of the strokes occur.
Yeah.
Okay.
And as you go up the brain, the vessel will become smaller and smaller.
Okay, that makes sense. And middle. Yeah. Okay, I get that.
Yeah. Have you guys heard of, when you see strokes, have you heard of like a thing called M1, M2, and M3? Have you heard of these things?
I've seen these before in reports.
Yeah.
I just ignored them.
Okay,
But
what
yeah.
what
You just
can-
ignore it.
I don't
No,
know.
that's fine. I
I
guess
don't
as
mean-
students we wouldn't know what they mean.
Yeah.
Would you be able to guess what they mean? So the M actually in this. I don't know.
Oh.
I'm gonna guess it's middle cerebral artery. The
Sure.
M stands for MCA.
Sure.
Are there multiple branches off the middle cerebral
Keep
artery?
going.
So like MC1 is one branch, MC2 is another, MC3 is.
Not
It's
really.
like how many
Not
branches
really.
are affected?
You're gonna be less likely to use a mechanical thrombectomy for an M3 compared to an M1.
Oh,
Why is that?
how long it's been blocked for?
How small
No.
it is?
Where
How
it is?
narrow?
Small is roughly where
Where it is.
So
Like, how
Is it too deep in the brain?
too deep, yeah.
Depth.
So too deep and too small into the brain. So
Right.
I guess logically it's harder for you to get that
Snake
tube
that
in
wire.
and whip
Wait,
it all
to
up.
help me imagine a thrombolectomy, how do they insert the tube into the? Where do they insert the tube in?
I'm actually not sure.
carotid artery, right?
So they
Just do the
do they
carotids.
start at the
Oh, no.
carotids
Oh,
and
you-
then bring the tube?
Yeah.
Let's
the
assume
wire.
they do. I don't know
Okay.
where they do. Yeah.
But they just they put like a little.
So I guess it's too hard to go up to M3.
So M3 is pretty much impossible to reach with a thrombolectomy.
With the mechanical.
With a
I
mechanical
think so.
thrombectomy.
Yeah, I think so. Yeah.
Yeah.
So that's the difference
Okay.
between the 1, 2, and 3.
So wait,
Yes.
so 1 and 2 you can potentially retrieve.
I think they usually only do 1.
Okay.
Unless you
Cool.
can do
So we were talking about the ACA, the MCA, and the PCA. So we're going to talk about clinical features. What are the known features of a stroke that you see? And-
I think you would hear slurred speech.
Okay, so you hear slurred speech.
Yep.
What area would this relate to in the brain, based on the things that I told you about earlier,
Yeah.
the regions of the brain and the
So
branches
would
of
that
the
be
brain?
like the Broca area?
Broca's area. Yeah, good.
Because Broca's the motor function of your speech, right?
Yeah, so good. So would that be a little more likely your ACA, your MCA, or your PCA?
Maybe
Your MCA, it's in the middle, right?
I think it's the middle of the brain.
Yeah,
But yeah.
yeah,
So
yeah.
it's more of the
Middle,
MCA.
yeah.
Okay. Is there another thing that we can think about that related to fast even?
Weakness.
Weakness. Yeah.
From weakness.
Yeah, good. So we're talking about weakness. Say, for example, it's weakness in your arms. You can't raise your arms, right?
Yeah.
That's the A in arms. Is that more, again, ACA, MCA, PCA?
Well, you said the
upper arms, so we're
it
talking
would
about.
be ACL, the anterior portion, because that's where the motor cortex is, the anterior portion of the brain.
I think it's MCA. It's all it's MCA. But but
Generally speaking.
it's MCA, right?
Yeah.
Wait, so can I clarify? So with the MCA, does that provide the blood supply to the motor cortex and the sensory cortex?
I think it's really hard to
Distinguish.
yeah.
No, I don't think so. I think if you think about the head in 3 dimensions, if you're looking at it from front to back, the middle part,
Anterior to posterior.
anterior to posterior, the middle part, say the middle
Yes.
third, let's say, is ACA. The lateral parts are what's called an MCA, and then there's a line that goes through,
Your jaw.
not through the jaw, through the,
just trying to
the
describe
brain,
the
temples.
Yes.
and then below that is the PCA.
Okay.
Mm.
Yep.
So generally speaking, like
Yeah.
that.
Okay.
Yeah. Good.
Yeah.
Okay.
That's what I think.
Yeah.
So if you have lower limb weakness, what artery is that generally gonna? Again,
So because compositing what Daniel and JT have said, so if you look at your brain anterior to posterior, along the middle of your brain, right where it's sort of where the cerebral sulcus is, that is supplied by the anterior cerebral artery, like the top.
Howls, right?
HAL,
Howls
yeah.
legs.
Yeah,
Yeah.
so that's
What is
supplied-
this? I don't
No,
know.
no. So I get there. So first off, that part of your brain is supplied by the anterior cerebral artery.
Yes.
And we know from the homunculus, if we put our boy Hal on our brain, its legs would lie in that part of the brain. Therefore, that your legs are supplied by the anterior cerebral
Can you
artery.
explain this HAL thing again?
Okay, so imagine you're tiny, Jason. You're like this big, okay?
This
You're,
big leg.
you're like this big.
So the size of your, the length of your face.
Length of my face, right? If I pick you up and I put you on my head, I'm going to arrange you so that your legs are in the middle of my head, and then your head is down by the side just towards my ear. So you're lying like this,
Yes.
okay? So if you're lying like this represents the...
So is my head inferior?
Your head is inferior. Your
On
head,
the lateral
yeah,
side.
you're lying upside down. So if you're lying like that, your head will be there.
Yes.
Your arms will be there, and your legs will be up there.
Facing
Okay.
the sky.
And if this part's supplied by the anterior cerebral artery, a stroke here will affect your legs.
Okay, that
That's
makes a
in
lot more
3D.
sense. Yes. Okay.
Make sense?
Yeah.
That's actually
Usually,
really useful.
if you have lower limb weakness and you do a neurological exam,
Yeah.
what neurological exam do you do for lower limb neurological? What do you get them to do first, other than inspection?
Stand up,
Stand up, and you get them to do what?
walk around.
To walk around, right? So what will you see in this situation
See
if they have lower limb weakness? And that's something that I guess
a shuffling gait.
that's more Parkinson's.
no,
I
you
guess
see
But they just
a weird
can't
gait.
What do you
reduce
call-
power. No.
apraxia, ataxia. I think it's apraxia.
Apraxic
Yeah, I
gait.
think it's apraxia. Yeah,
Okay.
good.
Okay.
What's another thing that's on the lower half of your body that's from your pelvis down that we ask for neurological signs?
Did you shit your pants?
Yeah,
Or did you wet
urinary or fecal incontinence it's more lower. And what artery is that we were talking about relating to HAL?
The anterior.
Anterior. Yeah,
He's got it. Jason's
Good.
got it.
Nah.
good.
Just give me my neurology degree.
So just now we were talking about expressive aphasia.
Yes.
And what part of that artery was that supplied by? And Broca's usually on the, middle lateral side.
It's kind of in the middle.
Yeah, so what artery is
So
that?
the middle cerebral.
Middle cerebral artery. Good. So there's expressive aphasia where you can't speak properly, where you can't communicate. So what happens when you see these on the patients? They're really frustrated with themselves because they know what they want to say, but they can't say it. And in reverse of expressive is
Receptive.
receptive, and what will they have trouble with?
So that affects the Wernicke's area.
Yep, okay.
The Wernicke's area is responsible for understanding language, essentially. Yeah, and comprehending something.
Yeah, okay. Yeah, good. And then finally, we go to the last artery that we haven't just really discussed so far, posterior cerebral artery, and
Yes.
relating to the occipital lobe, think back to what function that lobe was.
You're blind. Wait a minute.
You won't get blindness.
Oh, you won't? Okay.
You won't get blindness.
Oh, you get hemianopias.
Hemianopia.
Yeah.
Yeah. One thing I haven't discussed.
Yeah.
This relates back to our neuroanatomy days. Do you remember the thing called the desiccation of the pyramids?
Yeah, you mean decussation.
Decussation. Oh, sorry, I'm
Not
missing this.
degustate.
Desiccation of the
Desiccate, yeah,
pyramids. Yeah.
decussation.
So why is that relevant here, and why am I bringing that up?
Because I think if you have a lesion in the right side of your brain,
Yeah.
that can affect the left arm or left leg.
Good. Yeah.
So it's
Good.
what's that fancy word for it when it affects? Contralateral side.
This is right. Yeah.
Contralateral.
Contralateral. Yeah. So
Yes.
the hemianopia that we're talking about is also contralateral.
And then ipsilateral means same side.
Same side.
Ipsilateral.
Yeah.
Ipsilateral.
So rarely will a stroke be ipsilateral.
Yeah.
If it affects both sides, where does this suggest the stroke is going to be?
in the middle. Or if just affects
I think in
Are
the
we
brain,
talking about vision?
along with the brainstem. So we're going to management now, and let's generally just talk about ischemic stroke. So someone comes in, you don't know they have a stroke. What's the first thing that you do? We're talking about the first principles that we do every time.
We already taken a history and everything.
No. A, B, C, D. You have to make sure that they're breathing and
Yeah.
all those things.
Yeah.
But when you do take a history, which is the next thing, what's one of the things that you have to try to do within this history?
When did it start? When did you
Not the
first-
history questions. So I guess you want to suspect there are other causes. So what other causes could look like a stroke mimic? That's what I'm trying
Oh,
to get
right,
at.
okay.
Seizures.
Seizures, yeah, that's a good one.
Sure.
Yeah, good.
Hypoglycemia.
Hypoglycemia could look like
Diabetic.
stroke. Right.
Yeah,
Yeah,
gotcha,
good.
right.
So think of all these things that they
Gotcha.
might come in with, like a headache, right? A really
Yes.
terrible headache.
Yes.
What else could present as a headache?
Oh, head trauma.
Head trauma. Good. Yeah, good. Actually, that's one of the common reasons for a middle meningeal artery, actually, is due to head trauma.
So anything which essentially causes altered mental status.
Good, yeah. Infections or electrolytes, as you say, like if they were like
Okay.
alcohol withdrawal,
Mm-hmm.
drug intoxication. You want to rule out these other causes because you don't want to give them thrombolytic therapy if they're just hypoglycemic. Then you're
Yes.
pretty much fucked up, right?
Yes, fair
Yeah,
enough.
good. Okay, so we're suspecting the stroke.
Yeah.
It's still it's our main diagnosis right now.
Yep.
What should we do? So now we're talking about the imaging and things now.
Okay.
What's the first thing that we do?
So we've examined them and we've taken a
Yeah,
history.
so
Okay.
let's just jump
So
to the
our
juicy
main
part.
differential diagnosis right now is it's a stroke.
A working diagnosis.
working
is-
diagnosis,
Yeah,
yeah.
good. Is a stroke. So what's the first thing that we have to immediately do?
CT,
Good.
CT brain,
Good. CT brain, CT head. Yeah.
CT non-con brain.
Non-con. Okay. That was what I
Oh,
was going to get
fancy
at.
words. Why
Why
me?
do you think we have to do a non-con
'Cause
compared to a contrast?
If you're not sure if it's a hemorrhagic or an ischemic stroke, you don't want to give contrast because if it's a hemorrhagic stroke, the contrast will leak into the brain.
Good. Do you know how blood looks like in a CT? What
Like
color?
white?
Is it going to be black or white?
White, usually.
White, yeah, because it's more dense, right? So
Yeah.
it's going to appear like that. So if the contrast leaks out,
Obscures it?
it also looks white.
Oh.
So you don't know if that is going to be the contrast or the blood. So you're going to mislead it as a hemorrhagic stroke. So going back, the purpose of the non-contrast head CT is to do what?
To see if there's any areas of ischemia or reduced perfusion.
It's not ischemia that you're looking for because you can't really look at that in a CT. Yeah, so you're trying to exclude something.
Or exclude hemorrhage.
Hemorrhage. You're trying to exclude hemorrhage, so you have to use the
So
non-contrast.
you're doing a
CT.
non-con to exclude hemorrhage.
Okay, so the
Yeah.
the initial non-con is not to see ischemia or see absence of blood. It's to rule out hemorrhagic
Yeah,
first. Then you can
yeah.
initiate.
Then the further steps are to
Oh,
do the
that's
ischemia.
cool. So
okay?
with a non-con
That's-
CT, you can't see ischemic stroke if it's.
I think you
relatively-
can, but like I guess I can't tell right now. What I know is it's going to look really dark
Yeah.
compared to the other areas.
I have heard like ischemic strokes, like they don't always show up on CT.
Yeah.
Yeah,
depending-
and so the next things
Okay,
that we
that makes
discuss, there will
sense,
be higher definition
Yeah.
imaging that we'll talk about. But one thing I want to ask now is, so it could either be a non-contrast CT or an MRI. So both of these actually work. And MRI, as we know, is better preferred for what kind of tissue in our body?
soft tissue.
Soft tissue. So it's actually probably better in this case. Why is the diagnostic or like the rules tell us to use a CT? Have you
Takes
thought about
really
that?
long to get an MRI.
Yeah, good. MRI is longer. Is there anything else that
It's not as available.
good? Not as available in non-tertiary centers. And there's something that we have to check for when we look for when we ask for their consent.
Oh,
We got-
metal.
yeah,
They've
good.
got metal
And if they're
implants.
likely in a stroke, they're not.
Can't ask them that.
Yeah, they can't. Yeah, so it's much more easier, more
safer.
available. Good. All right. So our first step, if someone is suspected of stroke, the first thing that we do is a
CTB.
contrast, non-contrast.
Non-contrast.
CTB non-con.
And the purpose is to
See if there's any areas of any hemorrhage into the brain.
To rule out
exclude hemorrhage. Yeah, exclude hemorrhage. So say there's no hemorrhage. The next step now is to do what?
CTA. So
CTA. The A stands for?
angiography.
And the purpose of this is to
see if there's any ischemic areas or any blockages.
So
Good.
can you explain what a CTA is or CT angiogram?
It could be a CT angiography, or a magnetic resonance angiography. So they're both to check for the blood flow in the brain, I guess.
They're gonna, but there's so many blood vessels. Like, how do you know where to direct the angio tube or the angio wire?
Because there's going to be a blockage, so one of the blood vessels will just stop.
Like, wouldn't there be? Okay, I was just managing. There's so many.
You're correct. There are a lot of vessels, but for the angiography is for you to find out for any large vessels occlusions.
Because you use contrast.
Okay.
You use contrast, don't you?
No, but he said we did non-con.
No, for non-con. On CT brain is
Yeah.
non-con. And then if that's clear, you do CT angio
Oh,
with
okay.
con.
Yeah.
You didn't explain.
Yeah,
Okay.
yeah. And then you want to find any large
Okay.
vessel occlusion. And the purpose of this relates to the M1, M2, M3. What was I talking about earlier in the M1, M2, M3?
Mechanical thrombectomy.
So if there's a large vessel occlusion with the CTA, then you're looking for candidates for this procedure.
Mechanical thrombectomy.
Yeah,
M1 stroke.
Okay.
likely, yeah. And then this is something that you can do. It's also another type of CT. Do you know what that thing is? And you get a lot of color. You probably know, but Dan already knows. But you get a lot of colors in this, and it's really fancy. It's a CT with another letter. It's a three-letter word. CT, not A, CT, not...
Give us a clue.
Right, so you get different colors in this scan.
CTC? CT colored?
Good. You're looking for this different colors
Yeah.
indicates different types of blood flow in the brain.
Yeah.
So I haven't talked about this principle before, but usually a slow stroke is pretty good because you can get collateral blood flow around this
Yeah.
area of ischemia.
Yeah.
This area is called an ischemic. Have you heard of this word?
Yeah.
What is that word? Ischemic.
Bifurcation. No, I don't.
It starts with a P. It's this
You're talking
area.
about the penumbra?
Yeah.
Fusion.
So you're looking for the blood perfusion. This whole point of the CTP is to look for perfusion around this ischemic penumbra area to see if you can still save it or not.
Can I ask, does the penumbra refer to the area that you can reperfuse?
I think the area that's still alive.
Yeah, okay. And you can save.
I think
more
it's
or
like a
less.
donut. The middle area is probably dead.
Yeah, okay.
Might have to
What the
clarify
hell is
that.
a
yeah.
penumbra?
Go ahead, Dan.
Is it, I don't know, but is it just like a radiographic feature?
Yeah.
More or less. So it's there. You'll see the dead part and then an area, just a different colour on the CT around the outside of that dead part, and that area is
So
going to
if
die if you
part
don't
of
do
the
anything.
brain has a penumbra, means that it's likely to die.
Well, but the penumbra is the area you can still save if you
okay.
like
The middle
refuse
area
or
of the
treat
donut
it.
is already dead,
Okay.
which is good because the CT perfusion means that you can still save these
Yes.
areas.
Okay.
Sometimes you can't and there's no penumbra, then you're already too late because you're past
Oh.
your 4.5 hours.
Because umbral is shadow.
Oh,
Penumbra is the area next to the shadow. Because the shadowed area is the
not
dead part.
perumbra.
No, penumbra.
Not para.
Not para,
Para
no,
or whatever.
penumbra.
Peri or whatever. So many.
Yeah, so the area around
yeah.
the shadow, I'm guessing.
that
Because it
makes
shows up
sense.
like
Yeah,
dark
nice.
on the radiograph, right?
Nice.
I assume.
So you can either use a CTP. The P stands for what, Jason?
CT perfusion.
Yeah, you can either use a CT perfusion or a diffusion weighted MRI. And this can help you look at these colorful images. And I think different centers use different colors, but let's just assume red is like really a lot of blood and blue is no blood flow.
Sure.
So you get a rainbow of colors.
Okay, cool.
Yeah. So you find there's a blood clot in the M1 of the middle cerebral artery.
Yep,
Is a candidate for mechanical thrombectomy.
sure.
What's something that you should start right now, medication-wise, within the 4.5 hours?
Thrombolysis.
Yeah, thrombolytic,
Right,
thrombolysis.
thrombolysis, yeah.
Yeah.
Wait, so do you start? Okay.
So TPA is tissue, plasma, and
I thought you do.
Plasminogen
Plasminogen.
activator. Is that
activator. Yeah.
Wait, so do you do?
And that activates to fibrin, right?
Plasminogen lyses the fibrin clot.
Yeah.
Wait, so do you add a
Plasma.
thrombolytic agent even if you're doing thrombolectomy, mechanical thrombolectomy?
So there's apparently theories here, and you have to ask
Because
the
I thought you
consultants
choose
here.
either. It's like if you can't get to a tertiary center, you do thrombolytic agent, and if you are at a tertiary center, then you just do the mechanical surgery.
I think that the theories are you always do it, but then the risk is if it's a big clot and you use the thrombolytic agent, then it breaks up into many small
Yeah,
clots.
that's why I was like.
I think that's what they're dealing up with.
Imagine that.
But then
Okay.
but then the principle, at least at Fish right now, and I'm not going to call the consultant, but apparently this is the general knowledge, is like you do it no matter what, and then you still go in with the thrombectomy to pull out the stroke,
Right.
Okay, so there's thrombolytic agents,
which you should
which
always
is-
do.
What can you give an example? Is that streptokinase, altipase?
TPA.
Okay, so that's a tissue plasminogen.
It's RTPA, so
Activator.
recombinant.
So that-
I don't know. Yeah,
That essentially breaks down the fibrin
the clots.
clot. Okay, and then you've got the other one, which is a mechanical
Thrombectomy.
Is it called thrombectomy?
Yeah,
and that's when they
thrombectomy.
is that when they put a wire into the blood vessel and,
Yeah, and try to
take out
retrieve the clot,
and
yeah.
try to retrieve the clot. So
Yeah.
those are
Is
your
that
two
right, or-
options.
Yeah.
Yeah. Okay.
So those
Sorry,
are your two
cringing.
options. You're saying that sometimes they give the thrombolytic agent and then they do the thrombolectomy.
Thrombectomy.
Thrombectomy, so
Yeah.
And just to continue on with that, so I'm assuming, because they can give the TPA, assuming that's the synthetic one, right?
Yes,
And
yes,
they
yes,
can
yes.
give that multiple times if somebody has a subsequent stroke, as opposed to is streptokinase the one that's derived from bacteria and you
Oh,
can only
yeah,
give that
yeah.
once?
Yeah.
Oh,
Streptokinase
it doesn't work.
yeah.
Streptokinase is the one that only works once.
Yeah.
Yeah.
The
Yeah.
altipase, which is TPA, is the one you
Why
can
does
use.
it only work once?
Bacteria derived, and you get a immunological
Yeah.
response to
Ah.
it.
Yeah, antibodies, and you do remove.
So next time that you
Doesn't
give
work,
it.
yeah.
Oh,
Yeah.
that makes sense. Okay.
Yeah.
I forgot about that.
So that's the 4-step process, I guess, that you should do as
Yes.
I guess like a stroke workup.
Mm.
But then the other things that you should always do, if you check for AF, what should you do?
ECG.
ECG. If it's a longer 30-day thing, you
Holter
should do a
monitor.
Holter. Yep. If they're holding their neck, what should you look for?
Carotid
Carotid
stenosis.
Using what? What
Carotid
investigate?
Doppler.
Yeah, ultrasound to check if they have heart failure. I guess what could you do?
Echocardiography.
Echo. So those are the other things. There's I think a list of things that you should do, but these are usually done after the shit
'Cause
has
I'm pretty
been,
sure
has
with
been
the-
solved. Yeah. So these are there's a bunch of other things that you should do afterwards to help
Identify.
the cause of the stroke, so this doesn't happen again.
Yeah.
But the immediate thing that I was trying to focus on right now and try to get the principles behind was the 4 things that we're just talking about now.
Okay.
Yeah. And that's mostly for ischemic stroke. That's if you have a
Yes.
clot. If it's hemorrhagic, I'll just give it to you. It's usually
Okay.
just...
Oh yeah.
Sorry,
Yeah.
go ahead.
No, go for it. Yeah.
If there's a bleed, I think it's usually just neurosurgery. I don't know what exactly they do.
You do blood pressure control.
Well, yes, that. I guess this is related. So remember we talked about the 2 types of hemorrhagic stroke?
Mm-hmm.
What were the 2 that we're talking about? One that was in the brain and one was around the brain.
Yeah. Intracerebral.
It's in the brain, and around the brain is
Subarachnoid.
good. So if there's bleed around the brain, so this will go in the CSF, right?
Yeah.
What's something that you can do to see if there's blood in the CSF?
Lumbar puncture.
Yeah. So that's another. I guess if you go down that pathway, you do a
Okay.
yeah.
Makes sense.
If you suspect that. Yeah, good. So those are the first principles.
And I assume hemorrhagic stroke is just way worse for you than a ischemic stroke. It causes more damage.
I don't know.
Oh, okay.
I don't know
No,
what's
yeah.
worse actually.
But I
I was just wondering, like, mortality, yeah. Like,
I do know like strokes can like convert to the other one.
yeah.
Hemorrhagic transformation.
Yeah,
Yeah,
you can
so
get an
what is
ischemic
that?
stroke with hemorrhagic transformation, right?
Yeah, so do you mind explaining what that is?
JT, you know what it is?
I'm just gonna guess.
Yeah.
I assume it's a blood clot, and they haven't really figured it out, and then it just causes more hypertension, and then while you have ischemic stroke, you get a hemorrhagic
Yeah.
stroke as well.
Yeah, I think that's it.
No, I thought it was like when you have a ischemic stroke in the weeks after, like when you're doing rehab, you had a increased risk of that developing into a hemorrhagic
You might be,
stroke.
yeah. You might be.
Yeah. Okay. Yeah. No. Yeah,
Because
you're
I
right,
guess
yeah.
the blood vessel is already damaged, therefore
Yeah.
it's at increased risk of exploding. So,
Yeah.
are berry aneurysms, are they considered hemorrhagic stroke
Only if they
those
rupture.
explode?
Yeah,
So-
it's hemorrhagic stroke.
Yeah. So the word a subarachnoid is, I guess, is the typical Berry aneurysm.
Okay.
Did anyone want to recap the immediate thing that you should do? The neuro investigations.
Okay, so investigation. So if your working diagnosis is a stroke of some sort,
Yeah.
you do a non-contrast CT to rule out hemorrhagic strokes.
Good.
Okay. Then after that, you do a CT angiogram to try and find where the blockage is in the brain. And then after the CT angiogram, you do a CT perfusion
Yep.
to to assess the flow. And then after that, you look at whether you want to give a thrombolytic agent, which is a tissue plasminogen activator such as alteplase. Or you can go down the route of mechanical thrombectomy.
Yeah.
And from my understanding, you can do both. You can give the thrombolytic agent as well as do the thrombectomy.
Good, yeah.
Cool.
Yeah, that's pretty much it. That's all I wanted to talk about.
I learned a lot.
Yeah.
I'm ready to go on neuro now.
I learned how JT's American accent just slowly reduced over the 45 minutes. So. No, but thank you all for listening.
All right, Jason, what's the outro?
I don't know what the freaking outro is.
Thank you, everybody, for listening. We'll see y'all next time.
All right, it's cut.
Yeehaw, cowboy time.
Ciao.
I don't think that brain thing is worth it. Is it that important?
Hey guys, Dan here with some fact checking. So for JT's stroke killer fact at the beginning, stroke is the third most common cause of death in Australia and fifth most common cause of death in the US. In terms of the TPA timing, an injection of TPA can usually be given through one of the veins in the arm within the first 3 hours. However, sometimes TPA can be given up to 4.5 hours after the stroke symptoms have started. We had a discussion about the different terms that you can use to describe gait. So an apraxic gait is the inability to perform particular actions as a result of brain damage, versus an ataxic gait, which is the loss of full control of bodily movements. And finally, just to clarify exactly what we meant by penumbra in respect to reperfusion, an ischemic penumbra denotes the part of an acute ischemic stroke that is at risk of progressing to infarction but is still salvageable if reperfused. So basically, it's the part of the brain with changes on the CT that you can still save. Thanks for listening.